So I'd also like to thank the organising committee, and particularly Reno, for collaring me in a corridor and asking me to come and talk. I've been given a fairly long leash to talk about what I want, and there's a good chance Reno is going to regret that, but for now, we'll go ahead with it. So the official title is Safety and Quality, the JMO view. I think a better title is more about how I learned to start loving quality improvement. This is going to be short on data and facts and long on anecdote and autobiography. Hopefully it's applicable to other junior doctors as well. So I should probably start by saying I've got no declarations or conflicts of interest, but keen, and usually food, drink, that'll do it. I'm easily bought. But one declaration is that, as Reno said, I trained in the UK, so some of my terminology and the training scheme and so on are slightly different, but you know, it's all the same at the end. So just a quick illustration, if I use some strange words. You start at medical school, everyone does that. Then if you're going to be a paediatrician, you do 2 years of foundation stuff, and then 3 years of level 1 training, 2 years of level 2 training, 3 years at level 3 training, and that's assuming you don't wander off somewhere like I did, have a year in New Zealand, and then go back to the UK, and then wander to Sudan, and then go back, and then come to Australia. But this is the official terminology that the Royal College uses. No one in a hospital would ever use these terms to the consultant. They're just called a house officer, an SHO, and a registrar. Okay, so that's probably what I'll say halfway through, so just have that in your mind. It's a long old training scheme, and thankfully I've finally finished it, and I can see the light at the end of the tunnel, but then I actually took a step back into the tunnel to do a fellowship at Westmead. And you kind of, when you first start, you're at medical school, and you always look younger than you remember in the photos. But you assume that you're going to finish medical school and then you're going to change the world. That's why we all did it. We're going to save lives. We're going to be heroes, basically. And that's sometimes true, but it takes a while to get there. And actually, you tend to find that when you're first a junior doctor, you turn up on the wards thinking you're great, and actually, you don't know what's going on. No one trusts you, and you've been kind of given the little bow and arrow, for example. Because who would have a bow and arrow when you've got a superhero who's got an iron suit and someone who turns green? A bow and arrow, thanks. So you're mostly Hawkeye when you're a junior doctor. People from the outside think you're probably a hero, but you know deep down that you shouldn't be there. The other thing that actually happens when you're a junior doctor is that you spend a lot of time sitting at a computer. So I mean, Hawkeye's probably an exaggeration. You're more like these computer guys who are sitting there helping other people be heroes. And that's both good and bad. It's bad because it's not what you wanted to do, but it's good because actually you end up being at the forefront of a lot of issues. So if you want to know how well a computer system works in a hospital, ask the most junior doctor, because they're the ones sitting in front of it. If you want to know if the prescription chart is actually good at its job, ask the house officer, if you will, because they're the ones that use it every day, and they're the ones that have probably made a dozen mistakes that day already. So it's quite good from that point of view, and you get to see how things actually work on the ground. The other sad thing about being a junior doctor is that you spend a lot of your life wandering around like a hobo, because you just go from hospital to hospital, a bit like a hero whose job is done. You hit the road and go to the next place to try and save some lives again. And so for me, that involved traveling to all these countries, obviously not quite the right sizes. England is much smaller than that. But it meant that in my 12, 13 years of being a doctor, I've been in 15 different hospitals, done 24 different rotations, and that's including adult stuff, pediatric stuff, PICU stuff, some teaching, some voluntary stuff. And so you kind of almost feel like you don't belong anywhere. But then at the same time, you do kind of get to have the experience of working in different units, seeing what works and seeing what doesn't. And so after a while, you've traveled to many hospitals and you've realized that actually this worked really well in that hospital, why don't we bring it here? And you arrive at your next hospital, you have your induction, your orientation, and you think, right, I've got a great idea for how you can fix things here. And inevitably what happens is you're met by Dr. No, who says, this is the way we've always done it here, which has been described as the 9 most dangerous words in business. I think it's probably the same in medicine as well. I'm not going to name the hospital, but one of those stars on that dot, on the map before, at our induction, we were told by the clinical director of the hospital You are only here for 6 months. You might think you know how things are done better elsewhere. You will be gone soon. We don't want to know your ideas. So luckily not everywhere is like that, but it's something you do. You see it every now and then. I like to think I've met many more heroes than I've met Dr. No's, but you meet a few. And so what that does is it kind of beats the quality and safety person out of you, and you just keep your head down and you just do your annual requirements for your training because you have to get your tick boxes done. And your first introduction to quality, safety is audit. I don't know if you can see that there, but the main thing is you have to do one audit every 6 months as part of your training, get it signed off and complete the cycle, etc., etc. You're never really told what it is, why it is, or who it helps. And so here's an example of my early audits that I found on my CV. Exciting stuff. I think this was my expression when I was looking at the CV going, did I do that? Okay. I hope I did, otherwise I'm lying on my CV and maybe Rena should fire me. But the trouble is what happens is if you make people do busy work, essentially, they don't know what they're doing, they don't know why they're doing it, and so they just do the minimum possible. And it took me a good few years to actually do an audit that seemed to have anything to do with patients. And that was the very small-sounding audit of nutrient-enriched preterm formula. I was on a neonatal unit and was given the task of checking whether the babies were getting the right formula when they went home. I thought, oh, that's easy, I'll just do that, tick box. And just looked on the discharge letter and it went, yeah, they are getting prescribed the right formula. And then realized that, oh wait, just because I prescribed it, does that actually mean they're getting it? So I asked the pharmacist and he went, well, the GP has to prescribe it when they go home. We give them 28 days worth, but they need it for a year. And so I thought, oh, well, it's not technically part of the audit, but I'll just ring a couple of GPs. And so 20 GP surgeries later, I realized that basically no one was getting their formula after that 28 days because the GPs didn't know about it. And so we designed a pro forma that had to go on their discharge letter, and then miraculously they all got it when their GPs actually knew they were supposed to give it. So had some patients that hopefully got full tummies and were happy. It won an audit prize. And most importantly for me, it gave me the bug. I was bitten by the quality improvement bug, and I thought, right, I can do this. I can save lives. I'm going to be a hero. And like every young, foolish, naive person, I straight away overshot and tried to go too big too quickly. I did an audit with probably the consultant that got me really passionate about quality improvement, one of the consultants in Leicester called Simon Robinson. He said, we're doing a lot of drug errors. Why don't you have a look at what's going on there? And I was like, oh, great. What we do is just for 2 weeks, we'll just audit what's going on, and I'll just look at the charts myself, maybe ask the pharmacist, and then just work out how many errors we were identifying on our audit. And then, just for kicks, let's see how many of them are being reported on the incident management system. 71 errors, including dosing errors, illegibility, dilution errors. But, you know, a lot of them were about inotropes and a lot of them were about fluids, and they could easily have had negative impacts. How many do you think were reported on the incident system? 3, I heard. Very close, 2. So I thought, oh, this is a great audit. I've shown some deficiencies. And this was then presented at the local audit meeting with the chief exec and the drug committee head. And they didn't like it. They didn't like it at all. They were not impressed with our audits because of the deficiencies it showed in the system. They were angry. But it actually showed that having some data made them really enthusiastic about us changing things. And it was my first experience of trying to change a culture from below. It's quite good because actually, you know, I'm just about to admit that I've done most of the errors, but I was doing a lot of the prescribing myself, so probably some of those errors were me. But it also meant that I could change things by just being a bit more careful. And we realized a lot of it was due to interruptions, and so we made lots of boards about saying it's okay to say no about interruptions. And we created a little prescribing area in the corner of the unit, and some noise-cancelling headphones there that you got to put on when you're prescribing. It went well. We did monthly audits, and we had a reduction in prescribing errors. The important things that I learned were, one, if you wear noise-cancelling headphones while you're prescribing, you can still hear everyone mocking you while you're prescribing. But it's a visual aid and a little red tape as well. The other thing that we tried to do was to try and encourage people to report incidents. And we thought, oh, well, what we can do is basically buy them off. And so we had a competition that each month the person that reported the most incidents got, in our case, an Amazon voucher, although other multinational tax avoiding delivery agencies are also available. We quickly found out that that was not a popular move, because when you handed it to someone and went, well done, you've done the most reporting, they went, oh, God, I'm the snitch this month. So that didn't work. We stopped that quite quickly. But overall, it was a generally good experience. The main thing I think I learned from that was about the data being helpful. And so I went on to a Paediatric intensive care unit, and one of my roles as the senior trainee was to create a morbidity database. And so we collected data on bad things that happened on the unit. Obviously, cardiac arrests and patients almost arresting and having their chest open and things like that. We called those the major incidents. We also collected a lot of minor incidents, and this is about one of 3 slides that appears on our monthly data thing. And I think everyone's kind of on the same page that with a 3% mortality rate in the UK in the last 3 years in PICU, mortality isn't really where we're going to make many big strides in quality and safety, so it's probably going to be morbidity. And so we've been collecting this. Essentially, the night person ticks anything that's happened during the night, and the day person ticks anything that happened overnight, and it's checked every 24 hours. And then at the end of the month, somebody, usually me, and it's now the most senior trainee there, has to put it into a database and benchmark it against national averages and that kind of thing. So it's been quite useful in terms of giving us numbers for things to work on, and it's also been useful because you get patterns. And I think one of the most common patterns that you probably didn't even need to collect the data to work out is that every 6 months you get new doctors in and you get new nurses in. And so we had to try and educate them as well. What we found is that every 6 months the new doctors come in, they've got no idea what's going on, that you say, go put a chest drain in, they're like, oh, fine. And then suddenly the number of chest drains that fall out through accident goes up. Same thing happens, the new nurses come into the unit, and they're not sure what to do, and the incidence of pneumothoraces post-chest drain removal go up. And so I casually mentioned to the clinical director, wouldn't it be nice if we had like a collection of videos that we could just show people when they start? And he went, oh yeah, go on, do it. And so I did. It was also the same time that we were introducing the national standards for invasive procedures, and he said, well, you better put that in there, otherwise there's no point in doing this. And so we created this it's called Emergency Procedures in Paediatric Intensive Care video set. In retrospect, it should have been Essential Procedures, but I'm not going back and changing it now. So it starts with a sign-in, and then you have whatever procedure, and there are some medical ones, there are some nursing ones, there are about 20 in total, and then it has a sign-out at the end for the WHO checklist type NATSIPS project. It's been endorsed by the UK Paediatric Intensive Care Society, so it's on their website if anyone wants it. 20 videos there for free. Quick plug there. And it seems to have gone well. Has it reduced the incidence of all these problems? Sadly, I couldn't tell you because, as we've established already, I'm a hobo and I've left, so anything could have happened. But hopefully it's had a good impact. So then, as I said, I've left and come to Westmead. One thing that I've been involved with there is the implementation of a fast-track program for children's heart surgery. I'm not allowed to show you the data set that made this project happen because it's property of the ANSPIC registry, but essentially we had data that showed that we were the longest length of stay for elective post-bypass surgery and had the longest length of respiratory support. And a lot of that seemed to be because we would only extubate at lunchtime. If you weren't extubated between 12 and 6, you were staying asleep until the next day. And so we sat down, we did all our quality improvement methodology, found a load of things that we could try and fix in order to improve this. And we have come up with a fast-track program where, firstly, the anaesthetists who were super keen on this are extubating most people in theatre. And so actually, this was our usual technique for looking after patients. It doesn't project very well, but essentially the box at the top is the patient is in theatre. So God knows what happened before they came to us on PICU. And then they come down and they probably stay asleep all night on PICU because we want them to stay asleep because we want a quiet night. And then the next day we see about extubating them, and if they're not extubated, they wait till the day after, and then suddenly you're 3 days down the line when they could have been extubated on the first night. And so this is the list of things that we decided to try and fix. But I think the major one was, as I say, the anaesthetists who were saying, we'll just extubate them in theatre and take you out of the equation, essentially. And so they've done that. We've had, in fact, this is slightly out of date. We've got slightly higher numbers now. But most patients are being extubated within 4 hours of coming back to the unit or being extubated in theatre, and no one's been re-intubated. So actually, we probably could have done this earlier and wouldn't have been a big issue. And there hasn't really been any negative result from it so far. There will be, I'm sure, but hopefully we'll get over that with education and training. And actually, what we can see is when we started the project at that green line there, this was the average length of stay for these patients in 2017. And we were talking about the project here, and so people just started doing it before the project officially started. But since the official start date of the project, the median length of respiratory support for these patients is now 0 because they're all extubated in theatre. And then the length of stay for them is between 1 and 1.5 days based on bed block, essentially. But they're all sitting on the unit. And even if they're not discharged, we can at least say that being extubated is good for you. We've managed to reduce the length of stay by 0.65 days, and that's actually only in the last 3 months of data, which we've calculated that even if we don't extend the list of patients, at the moment it's only patients over the age of 6 months. But if we leave it as it is, then by the year we'll have saved 70-odd bed days, which will make us able to do the equivalent of 50 more fast-track patients in a year without any extra money, without any extra beds, which, you know, sounds good. So I think it's fair to say that I've definitely got the bug now and feel like I'm going to take on the world. And so every quality meeting I'm sitting there going, oh yeah, let's do this, oh yeah, let's do that. So I'm going to do some delirium scoring and some fluid calculating and extubation checklists and ultrasound stuff and drain replacement stuff and other stuff. But, you know, I'm pretty sure that not all of that will happen, but hopefully some of it will. And that's what the bug has taught me. So that's really the end of my rambling journey. Well, I hope not the end of my journey, but the end of this part of my rambling journey. I think it's probably fair that there's been some Spider-Man references in this, but I think that's probably the wrong superhero to call a junior doctor. I think we're more like Ant-Man. A lot of the time you're small, you're a tiny little cog in the wheel, and you feel like you're fighting tiny battles that mean nothing to anyone. But every now and then you can do big things and really live up to your promise of being that hero you wanted to be in medical school. So thank you.